of my French you'll probably hear this morning, but it's a great pleasure to be here. I'd like to thank the Scientific Advisory Committee for inviting me and specifically Julio Montané. Well, I don't think any of us can give a talk anymore without entering what has become the world of cascade. And so let me see if I can make this very simple, powerful bar graph that many of us see at least 50 times per scientific meeting just a little bit more entertaining. And if the public health value of the treatment cascade has not affected you before, perhaps it will now. So here we go. That didn't work, maybe a little more. And then if that didn't work, just a little shake there. So I joke, of course, but only about the pyrotechnics. I do want to say that the power of the cascade has been incredibly helpful to us in New York in terms of bringing our community, our politicians, our academics, the press, and our public health practitioners all into a very new alignment that I believe has not really existed in the same way before. This alignment is powerful not only because of the science, but because of its simplicity and clarity, and it affords all of us a unified vision for action that in the next several years we hope to take to continue to dramatically reduce HIV transmission in our city. How we wish that we all had the tools at our disposal that we now have back when the very first HIV and AIDS cases were counted in New York City, shown here as the very first surveillance counts. If we had those tools, we could have used treatment to prevent what has become a very complex picture. This slide shows the enormous impact that HIV/AIDS has had in New York City since the first case counts in 1981. While this slide is very complex, it really gives a historical account of our entire epidemic in numbers, and I want to highlight several important trends. First, you can see that AIDS diagnoses and deaths peaked in New York City in the mid-1990s, and these trends are represented by the red and black lines. We did not have HIV reporting until the year 2000, when the second portion of each bar on the bar graph, that's the darker bar, gets added. Prior to 2000, we only had AIDS case reporting. However, we can see from 2000 onward, the number of new diagnoses of HIV and the number of AIDS cases have declined consistently, even in the face of increased HIV testing and a steady rise in the number of persons who are living and not dying from HIV, increasing the pool of potential individuals able to transmit virus. You may be able to see as well that the slope of the downward curve on new diagnoses has accelerated since 2008 for the city as a whole. And also, as many of you know, New York City is made up of 5 boroughs comprised of more than 8 million individuals. And just for a moment of perspective, so that you understand the challenge that New York faces and the different scale of each response in the different cities in the United States, San Francisco is approximately the size of one of these boroughs, the Bronx, where new diagnoses have quite similarly been reduced by more than half in the past decade, from 1,346 in 2001 to just about 600 in 2011. In each of these 4 key domains in the care continuum, we're working to optimize scale and evidence-based strategies in New York City. I'm not going to read all of these approaches here, but I will spend the balance of my time highlighting some of these important approaches and some of the more interesting aspects of them. In essence, there are 3 critical domains of change in New York City that we're really emphasizing in all of our work. Of course, all leading to universal offer of treatment and maximizing viral load suppression. And these are using the law, policy, and system-level approaches to change the context of HIV treatment and care, maximizing technological approaches where possible, enhancing the use of our registry data as allowable by law to help providers more efficiently address gaps in the treatment cascade. A very important example of the legal and policy change took place for us in New York City in 2010, when the New York State Legislature overhauled its testing regulations, making New York State the first state in the U.S. to include a mandatory offer of HIV testing to all persons aged 13 to 64 in most healthcare settings with limited exceptions. The law included several other helpful provisions, such as the simplification of the written consent process. Prior to that, we had a separate written consent for every HIV test conducted, a requirement to actively link individuals to HIV primary care, and simplified lab ordering. Early evidence of the impact of the law has shown that it has had a moderate but significant impact on continuing to expand HIV testing. As part of an evaluation of the law conducted jointly between New York City and New York State Departments of Health, A survey of 215 labs found a 9% increase in HIV tests offered in the 13 months before the law as compared to the 13 months after the law. Also, data from our primary care information project. This was a project begun by now CDC Director Tom Frieden when he ran the New York City Health Department, in which community health centers and small private practices located in neighborhoods with high health disparities receive a free electronic health record system in exchange for sharing data. Using this data source and pulling information from 97 community health centers and small primary care practices, we find a significant increase in the percent of practice patients who have an HIV test in the preceding 12 months among the age groups recommended by the law, that is among 13 to 17-year-olds and 18 to 64-year-olds, but no significant change among those age 65 and over. Finally, our New York City Community Health Survey, which is an annual survey of 10,000 New York City residents age 18 and older on a variety of health behaviors, show the share of New Yorkers 18 to 64 who report ever testing for HIV continues to climb, reaching 68.1% in 2011. Many of those in the room from the United States have heard me present before on the piloting of a jurisdictional approach to HIV testing. And so I will very briefly summarize here the community mobilization efforts we have undertaken in two boroughs of New York, the Bronx and Brooklyn. These borough-wide initiatives have mobilized as many stakeholders as possible within each borough, including all of the hospitals, clinics, community health organizations, community-based organizations, faith organizations, colleges, and others, to publicly partner and endorse the notion that all persons in that borough, age 13 and older, should know their HIV status. To become an initiative member, partners had to support testing in the ways that they could, including changing logistics in their institutions, holding testing events, or promoting testing. Those that conducted testing had to report quarterly data to the health department, and they were required to attend technical assistance workshops provided by the health department. We also provided free test kits for those who were uninsured in the borough. The first pilot, the Bronx Knows, launched in June 2008, and we had community health survey data that showed approximately 250,000 people in the Bronx had never been tested for HIV. So over 3 years, that was our goal in terms of the number of tests to conduct. By the end of 3 years, partners had conducted more than 600,000 tests and identified approximately 1,300 newly diagnosed individuals, linking approximately 3/4 to care. And as of 2011, when the initiative ended, our community health survey data indicates that about 8 in 10 Bronx residents aged 18 to 64 report now that they have ever tested for HIV. And details of this initiative have been recently published in JAIDS. We took this concept to Brooklyn with Mayor Bloomberg formally launching the initiative on World AIDS Day in 2010. Now, Brooklyn, as you can imagine, is twice the size of the Bronx and far more complex demographically and culturally. Using our CHS data, we were able to estimate that approximately 580,000 Brooklyn residents aged 18 and older had never been tested for HIV, and so this is our goal over 4 years. The preliminary results we have to date, after 2 years, indicate that we're on track to meet this goal. In the first 2 years, partners have conducted over 300,000 tests and identified over 1,100 new positives. And clinical sites, as you can see, are conducting the bulk of the testing. This map from the Community Health Survey data shows the 5 boroughs of New York with past year testing rates by what are called United Hospital Fund neighborhoods, basically a collection of postal codes. If you're not up on your New York City geography, the 2 clusters in the darkest orange tones, indicating the highest past year HIV testing rates, align nearly perfectly with the entire Bronx and most of Brooklyn, the 2 boroughs in which our community mobilization efforts have been strongest. Moving to linkage to care, I'd just like to highlight the expansion and modernization of our partner services response through what is called the Field Services Unit, also a Tom Frieden invention, and begun in the summer of 2006, initially serving fewer than 10 hospitals located in high prevalence neighborhoods. At these hospitals, the health department stations on-site public health advisors to assist by conducting in-person interviews among newly diagnosed individuals for partner elicitation, partner notification, and partner testing, as well as ensuring that newly diagnosed individuals are linked to HIV primary care. This year, the Field Services Unit now serves all providers in New York City diagnosing more than 10 new cases per year, and every single diagnosing provider in the Bronx. So just to know the scale, overall in New York, we have about 2,000 providers. Perhaps most importantly, we're bringing partner services, maybe kicking and screaming, into the 21st century, providing laptops to public health advisors so they can do real-time registry lookup in the field, use Blackberries to text partners, boosting their response rates, and piloting an EHR-based direct provider request for partner services so they don't have to make a separate phone call. In terms of engagement and maintenance and care, as well as treatment adherence, we began funding new programming at the end of 2009 called Care Coordination, which is a medical home model and provides intensive return-to-care support, social service support, patient navigation, and treatment adherence, including directly observed therapy for those who need this service. The program focuses on serving newly diagnosed individuals, or it's a subset of individuals. So those who are newly diagnosed, those who are previously lost to care or never in care, those who are irregularly in care, or have viral rebound or resistance. More than 6,000 individuals have been served in this program to date, and this slide just shows where the care coordination programs are located on the top of HIV prevalence. Recently, our monitoring and evaluation team, led by Dr. Mary Irvine, has been able to conduct an evaluation of this program, matching data from program clients to our HIV/AIDS registry, and looking at 12-month pre- and post-enrollment to compare outcomes. The two outcomes being evaluated were engagement in care and viral load suppression. And here are quickly some preliminary results. Among those previously diagnosed with HIV, those in care coordination were significantly more likely to remain in care, engaged in care, and the percent of clients with viral load suppression was also significantly higher after enrollment in care coordination than before, even for clients previously diagnosed who had been in care. In New York City, in fact, the probability of achieving viral load suppression at 6 and 12 months after a new diagnosis has been improving every year, and this graph shows the years 2006 to 2009. In 2010, more than half of those newly diagnosed that year had achieved viral load suppression at 12 months. And recently, one of our CSTE fellows, Laura Stadelman, had quantified the improvement in a different way by looking at durable viral load suppression, or the percent of persons living with HIV in the registry who had all of their viral load suppressed, comparing the 2010 to 2011 and 2006 to 2007 time periods. And she found a 37% increase in the durable viral load suppression and a concomitant 34% decrease in the percent of individuals with a sustained high viral load, that is, with 2 consecutive viral loads of greater than 100,000. And this evaluation was presented this spring at CROI. So in 2010, nearly 3/4 of all persons living with HIV and in care had an undetectable viral load at their last recorded viral load. And finally, by 2011, the cumulative power of recent science, capped off by HPTN 052, led us to make the decision, along with San Francisco, by December 2011, to officially release citywide a recommendation to universally offer treatment to all persons living with HIV, regardless of their CD4 count. And as you know, 3 months later, DHHS released similar recommendations. So I want to close essentially with one innovative way that we're trying to advance this policy directive and build in some accountability. And we're using our registry data to promote these successful outcomes by something that we're calling care continuum dashboards. We would never call it a report card. This tool is a set of facility-level indicators developed so that our hospitals and clinicians can measure their own progress toward the national HIV/AIDS strategy goals. These were first piloted among 9 care facilities about 1 year ago, and the feedback was actually quite positive. We were a bit surprised. The first formal dissemination occurred just this past December, and they were sent, these sites, a formal cover letter from our assistant commissioner with an FAQ about why we were developing them. We call them CCDs. The CCDs were sent both by email and snail mail to the hospital or facility chief executive officer, the hospital or facility chief medical officer, and the HIV medical director. For the first round, the 21 largest facilities and our public hospitals, which are called Health and Hospitals Corporation, or HHC, received them, and these institutions comprise more than 50% of patients in care in New York City. The 2 core indicators are timely linkage to care of patients newly diagnosed at their facility, that is linkage within 3 months, and viral suppression among patients known to be in care through our registry. And this is what the sample CCDs look like. So you'll see we have a goalpost there. That's 85% linkage to care for the national strategy. The first bar is the citywide linkage rate, and the second bar is the facility-specific data. And you'll see that linkage is broken down by whether an individual was linked at their own facility or somewhere to another facility. This is what the viral suppression dashboard looks like, and it's set up the same way. And to date, I will say surprisingly, we've received uniformly positive feedback about the CCDs. Sites that have not received them are wondering when they're going to get theirs and how we can help them find the patients that they cannot locate. So we're working on that. So what are some of our next steps in New York? Well, keeping with the theme of the 3 domains that I mentioned at the outset, in the area of policy and system level change, we are working to remove all remaining barriers that we have in New York to routine opt-out screening. We're working to engage our hospital and facility risk managers so they understand the potential liability if they do not maintain standard of care with respect to the new testing law. We are working to fund system-level change projects in clinical settings that shift logistics, and we're looking to build quality indicators throughout the system around testing, linkage, and viral suppression. In terms of maximizing technology, we're trying to accelerate the CDC testing algorithm so that all sites that can adopt a 4th-generation HIV screening modality do so. And we're working to modernize and automate provider reporting and partner services requests. And finally, we'll be in terms of using our surveillance registry data, we will be issuing our CCDs biannually, and we're working on facilitating automated provider follow-up requests. So I'd like to close by showing all of you an extremely hopeful graph. This is what happened in New York City when we changed our laws around routine screening for pregnant women and made HIV testing and care the standard. From a peak of more than 300 babies born with HIV each year in New York City, we had 2 babies born with HIV in 2010 in all of New York State. We can do the same for all of our people, not just our pregnant women, when treatment becomes the standard of care at all CD4 counts, both for optimal individual and public health outcomes. And I'll stop here. Here we go. We can and should put ourselves out of business and help at least AIDS, if not entirely HIV, go the way of a once seemingly ubiquitous item in the United States that we thought we'd never get rid of, the Hostess Twinkie. And I'd like to acknowledge the incredible work of our entire team and our federal partners and funders at HHS, CDC, HRSA, and SAMHSA. And also I want to add Ron Baldessari, who's here, but not on this slide. Thank you very much.